Post-stroke muscle tone impairments refer to a range of muscular conditions that can significantly impact recovery and daily functioning following a stroke. These impairments, including spasticity, flaccidity, rigidity, dystonia, and clonus, arise due to disruptions in the communication pathways between the brain and muscles. Each condition presents unique challenges, from increased muscle stiffness in spasticity to decreased resistance in flaccidity, ultimately hindering mobility and rehabilitation efforts. Understanding these impairments is crucial as they play a vital role in the recovery trajectory for stroke survivors. The prevalence of muscle tone impairments following a stroke is notable as they affect a large proportion of survivors and contribute to long-term disability. Spasticity, for instance, is one of the most common consequences and can lead to significant complications, including joint contractures if left untreated. Rigidity, dystonia, and clonus further complicate rehabilitation, as they can restrict movement and increase discomfort, making it essential for healthcare providers to address these issues promptly. Several factors influence muscle tone after a stroke, such as the stroke's severity and location, the duration of the acute recovery phase, and individual patient characteristics like age and pre-existing health conditions. The intrinsic properties of muscle fibers also affect muscle tone. After a stroke, the mechanical properties of muscles can change, leading to stiffness and decreased range of motion. These changes may result in abnormal muscle behavior, including increased resistance to passive movement, which can contribute to the development of contractures. The central nervous system is paramount in regulating muscle tone. After a stroke, communication between the brain and muscles is often disrupted, leading to an imbalance of signals that can result in either hypertonic or hypotonic muscle tone. Lesions in the upper motor neurons can lead to spasticity, characterized by increased muscle tone and reflex. Spasticity is a common consequence of a stroke and is defined as increased muscle tone leading to stiffness and involuntary muscle contractions. It occurs due to disrupted communication between the brain and muscles, resulting in an imbalance of signals that control muscle contractions. This abnormal increase in tone typically manifests on the side of the body opposite the brain lesion and can lead to functional limitations in movement, making activities of daily living more challenging. Spasticity may also contribute to complications such as joint contractures if not adequately addressed. Characteristics of spasticity are stiff, tight muscles, exaggerated deep tendon reflexes, involuntary muscle spasms or contractions, resistance to passive movement, which is more pronounced with faster movement. Upper limb is manifested as flexor spasticity leads to clenched fist and bent elbow. Lower limb is manifested as extensor spasticity leads to stiff knee, pointed toe. Spasticity results in difficulty with movement and coordination, risk of contractures and permanent shortening of muscles or tendons. Flaccidity, or hypotonia, describes a decreased muscle tone, where affected muscles feel floppy and exhibit reduced resistance to passive movement. This condition is often observed immediately following a stroke and may hinder voluntary movements. Flaccidity is often temporary and may progress to hypertonia or spasticity as the central nervous system begins to recover. In cases of complete paralysis, known as hemiplegia, the affected limb can exhibit significant flaccidity, which can impact rehabilitation efforts and recovery outcomes. Characteristics of flaccidity are limp, loose muscles, absent or reduced deep tendon reflexes, difficulty initiating voluntary movements. Flaccidity leads to increased risk of joint subluxation like shoulder subluxation in the affected arm, and challenges with posture and balance. Rigidity refers to increased muscle tone that leads to stiffness in the muscles, causing resistance to movement throughout the range of motion. Unlike spasticity, which may fluctuate in tone, rigidity is characterized by a constant state of muscle tension that can severely limit mobility and contribute to discomfort. Rigidity is not velocity dependent. It is less common after stroke but can occur, especially if there is damage to the basal ganglia or other motor control areas. Rigidity is characterized by stiffness in muscles during both active and passive movement, difficulty with smooth coordinated movements, pain and discomfort, and reduced range of motion. Cogwheel rigidity is a type of hypertonia characterized by intermittent resistance to passive movement, giving a jerky, ratcheted feel similar to the clicking of a cogwheel. Dystonia is characterized by involuntary muscle contractions resulting in abnormal postures or twisting movements. Abnormal postures like foot inversion, wrist flexion. It can be focal and affects one area or generalized. Following a stroke, patients may experience dystonic movements that further complicate rehabilitation efforts and functional mobility. The underlying mechanisms of dystonia may be related to neurological damage and altered neuronal signaling patterns after a stroke. Clonus is a type of muscular response characterized by rapid, rhythmic contractions and relaxations of a muscle group. This condition often occurs in response to rapid stretching of the affected muscle and can be a sign of hyperexcitability in the neuromuscular system following a stroke. Clonus is commonly seen in the ankle as foot jerking or wrist. Clonus can impact balance and control, contributing to falls and further mobility issues. Effective rehabilitation strategies are crucial in managing abnormal muscle tone. An individualized rehabilitation program is essential and should start as early as possible, ideally from the first day following the stroke, to optimize recovery outcomes and prevent complications. Physiotherapy plays a significant role in this process, utilizing techniques such as proprioceptive neuromuscular facilitation, stretching exercises, and strength training to improve muscle function and reduce spasticity. Tailored exercises are designed to reduce spasticity, improve movement, and prevent muscle atrophy. Techniques such as strength training, task-oriented training, and walking or balance training are integral to this process. Targeted exercises strengthen muscles surrounding spastic muscles, improving overall function and supporting better movement patterns. Regular stretching is vital for maintaining muscle length and preventing contractures, particularly in spastic muscles. Functional training focuses on enhancing the patient's ability to perform daily activities, such as walking and grasping objects, which contributes to greater independence. Functional training emphasizes daily activities to maximize independence and provide restorative strategies and adaptive equipment to facilitate meaningful tasks, enhancing motivation and recover. Electrical stimulation involves applying electrical impulses to the muscles to promote contraction and movement, particularly beneficial for patients experiencing flaccidity or spasticity. In constraint-induced movement therapy for upper extremity training, the strong arm is constrained, forcing the patient to utilize the weaker arm, which can help improve motor function over time.